Share my screen. Welcome to 15. All right, module 7. I have to say, so I talk about one of the biggest things for vocal abuse is yelling. Oh my gosh, I've been yelling in my mask at arrival and dismissal at my school job. And I was so hoarse this weekend. Oh, and you know, my principal, she's not a real big fan of bullhorns, but I ordered one. I don't know, the whole arrival and dismissal is different this year, but I'm like, I'm exhausted after 10 minutes of yelling over through my mask and no one can hear because it's so muffled. So it's really, and it's so funny because I was talking to a couple of the other therapists and they're like, gosh, I'm getting hoarse every day. And I don't know why we all scream on Zoom, but we do. So I ordered a bullhorn and I told my principal, I said, look, we're going to be out with vocal abuse problems. And I said, the only way to get rid of hoarseness caused from vocal abuse is to not use your voice. So that means like, you know, teachers out for 2 or 3 days for vocal rest because we're yelling through masks. So no, bullhorn it is. Okay. Remember, amplification is the best way to reduce vocal abuse behaviors. Okay, hearing impairment. An observation, somebody just, we don't have good, and I think I put some different videos. So if you watch the one that I recommended or told you to pick one, a lot of it's hearing aid or it doesn't fulfill, it'll say something like it doesn't fulfill the requirements, but at least it's just hearing impairment. So some of the things that I would say what we see most of all that people struggle with is getting the right assistive technology to support their hearing. All right, hearing impairment and oral rehab. So let's talk about that a little bit. Hearing impairment, gosh, I was just reading, you know, the popular vernacular, I don't know, the way I've been saying it lately, but I feel like I just was reading something this summer that was correcting that. So I usually will say someone with a hearing impairment. Again, deaf culture, I usually refer to somebody who is deaf. Again, I don't always know how they identify. So if they refer to themselves as deaf, then you can refer to them as deaf. But okay, all these new things. Hold on, this is popping up. Okay, hearing impairment. Let me get this at the presentation. So, key thing, please remember, I need to relook up, I think we're still about right. Although hearing loss, we're getting better at diagnosing it and catching it. So this is really good. And I feel like we have better information about hearing loss prevention. But types of hearing loss, conductive, sensory neural, and then mixed, and then auditory processing disorder. Two things I want to focus on. So conductive is usually when someone has middle ear problems. So middle ear problems, it's usually a conductive hearing loss. Sensory neural is when there is damage to the neurons. So a lot of times conductive can be temporary, not always. And then sensory neural is permanent. So definitely, you know, the onset of hearing loss can vary, but if anybody's had a child recently, you'll know they screen all newborns for hearing, which is great. So, well, what do we know? Early intervention is the best prevention. So there are people born with a congenital hearing loss, and sometimes it's not noticed till much later. So if we have an idea that somebody has a hearing loss, and if we can judge the degree, we can start to make some supports in that person's life to counteract that. So some other some other things too. Time of onset. So that's why the goal is all infants with hearing loss be identified before 3 months of age. So if you were born with a hearing loss, the goal is to be identified by 3 months of age. So that's why they do that newborn hearing screening in the hospital, and that you receive intervention by 6 months of age. It is super, super critical that early intervention, because I don't know which course we talk about this, but really when we look at language, so our language window is the most open. Birth to three, birth to 5. It's like birth to 3 is a huge window. Birth to 5 is still a large window. But after that, the window kind of closes. So looking at, you know, the language, the bulk of your language, meaning not that you can't still develop vocab, but I'm talking your core language skills. In fact, one of our tests called core language, and I always think of it that way. It usually doesn't change after like 4th grade. These scores rarely change. That's like their core. So, you know, we're looking at 9, 10 is when that major language window is there. So the further we can get, either something like if the parent wants to do a cochlear implant, but hearing aids, but the more they hear and get in their, it's important for their language development. So super, super, super critical time frame. So you need to look at some of the degrees of hearing loss on the quality of life. Now, time of onset. Congenital means they were born with it. Prelingual means they have a hearing loss that developed after they were born, but really before they started talking. Postlingual is it developed after they learned language. So then there's some others. So we have deaf, deafened. Sometimes things happen, cranial nerve stuff, and sometimes they can have massive hearing loss from other reasons, not necessarily damage to the ear, but damage to the cochlear, vestibular cochlear nerve. And then, you know, sudden and progressive. So a lot of times too, there are some diseases where hearing loss just progressively gets worse. So it's okay now, but it keeps going down. So I've experienced a few different clients with this, and definitely what's good about knowing that is you can help offset some of those difficulties. So, and then degree of hearing loss. So we talked about the 3 main types are conductive, sensory neural, and then mixed. Sometimes they've got conductive problems and sensory neural problems, and that just exacerbates the issue. The degree of the hearing loss. So there's minimal, mild, moderate. I was just saying I need to get my ears checked. I might be in the mild range. I can't hear anything lately. And through these masks, I really can't hear anything. So then etiology. So what is the reason for the hearing loss? Sometimes we know. Sometimes it's genetic. So a lot of times families that have this gene in their family, they're aware of, they know it could be passed down, how to test for it. Bacterial, viral. So sometimes you have hearing loss. So I have one right now, he got meningitis, now has hearing loss from the meningitis. There's metabolic, there's trauma of all different sorts. Ototoxic. So when we talk about ototoxic, something that's toxic to the ear, biggest one being pharmaceuticals. So someone has maybe had, not radiation, chemotherapy. The chemo can cause, you know, permanent hearing loss. Some of these drugs that we take, these super amped up antibiotics, can definitely be ototoxic. So, you know, it's kind of like, do you need to get better, or are you too concerned about, you know, need to get better, or might lose some hearing in order to get better? So a couple things too, ototoxic drugs are super, those are ones that can happen for a variety of reasons. Definitely types of cancers can impact, vascular disorders, and then myelization. So, and really what we're looking at, some of these progressive neurological diseases can then cause hearing problems. And, you know, like I said, a lot of a lot of the reasons are it's genetic. And definitely what we see too is, I wish everyone would just get a genetic test if they have some of these difficulties. We can have much better information about it. But now that testing, the more testing, the more our better our technology, the better our ability to get information from the test that we give patients. They are finding more specific genes. They are finding more things that can be targeted to offset hearing loss, that kind of thing. So I do think some of this genetic testing has been phenomenal for something like hearing loss. So the other key component, sorry, I have to move this. Okay, so the other key component is amplification. One, my SLPA that moved away last year, I miss her dearly. Her husband, she was telling me, we were talking about, hearing loss, and he said he couldn't hear, or whatever it was. So she was going for his hearing test, which is important, and it's important for his new job. And they were talking about, well, what if you really do have a hearing loss and you need a hearing aid? And just talking about wearing it. So this is what we do know, is a lot of people do have a hearing loss, they have a hearing aid or some type of amplification device to help them, and they don't use them. Only 25% of them use them. So that's the other key piece, which I think is where we fall short. It's the rehab. We're good at diagnosing, we're good at finding what type of hearing aid, but really the amount of work that goes into adjusting the aid, whatever it may be, is what I think is some of the challenges. So again, looking at prognosis of hearing loss. Now, what I can say is if they've had a hearing loss post-lingual, so after they developed, so this particular person I'm working with right now, he got meningitis, I don't know, 7 or 8 years old. So he had some language before that. And the good part for him, though, I give his mom all the credit to this. She's really worked hard on finding him amplification he will wear. And as a freshman in high school, they don't want to do any of these things. So I give her a lot of credit. She's worked really hard for him and encourage him to wear his hearing aids. And this is what I do know, is most of the time, if they feel like it's benefiting them, they wear it. So if somebody's not wearing their hearing aid, probably is going to require some more time and effort with the audiologist to adjust the aid accordingly. So that's what I think what's hard about hearing loss, is finding how the audiologist can adjust it to meet your needs. And the other part is wearing it long term. So sometimes in an office, I just had this problem with my glasses. Feels really good in the office, but now day in and day out, they're maybe a little too high for me. Like they're maybe just a little bit. Good for driving, but like day in and day out all day, I think they're giving me headache. So I'm not wearing them, and I should be wearing them. So I think hearing aids can definitely fall in that. They know they should wear them, they have them, but it requires some more adjustment to get it right. So other things we see here are some of the errors. Definitely hearing loss, and when I hear this in a young client, I always want to make sure we rule it out. So when we're diagnosing speech and language disorders, we always have to rule out hearing. And if they do have a hearing loss, we know the reason for some of the speech and language difficulties. We still provide support. So somebody was asking if they're deaf or they have a hearing loss, we don't support it. We absolutely still support it. But we also have to be realistic about what the capability is in all ways of language and speech. So sometimes we're just going to try to get as functionality versus perfection, or make somebody sound like they don't have a hearing loss. The biggest challenge are those segmental. So we hear kind of those vowel neutralizations, sometimes nasal, it starts to get some, we call nasal or less, more nasal or less nasal. The voice and voiceless sounds, they don't hear those subtle differences, or they voice everything. So that's what makes their speech a little different. And then like children with significant hearing loss and use hearing aids have a distinctive speech quality. So I keep looking at this. I have a kid who stumbles me no matter how many years as a therapist. And every time I get an intern, every time a new person meets this poor little guy, I'm like, why is he not wearing his hearing aid? He clearly has a hearing loss based on how he speaks. And he does. He talks like somebody with a significant hearing loss, but I keep sending him to the audiologist and he does not have a hearing loss. So he's always intriguing to me. Even the audiologist is like, he's a case study. Because he's like, right when he walked in, I said, oh gosh, yeah, he's got a hearing loss. And then she does his test and he's been on his, I don't know, 4th audiogram in 2 years and nope, no hearing loss. So anyway, definitely we see some of these outcomes. So if you kind of look at the characteristics, so a lot of times we see restricted vocabulary. They can have some pragmatic difficulties. They can't necessarily follow a conversation. They don't, what I would call, intrinsically learn things because they don't hear it. They might need more of those nonverbal cues to help them understand. A lot of times they have more limited language and literacy skills because of their hearing loss. So definitely look, I'm not going to go through all these, but a lot of times what we do is we teach them repair strategies. So this little guy, I see, oh gosh, I love him to death. He's great. And for a freshman, I mean, he really works for me, but he wants to learn how to do those communication repair strategies. He wants people to understand him. He has a lot to say. So I have to appreciate how much his previous therapists have worked with him on this and how much he's also willing to continue to work on. And now being in a new environment, I think it's been a little intimidating for him. I think it's always a hard adjustment for those kids to be in one environment, one school, or then go to the next. So, and he'd like to get a job soon. He's old enough to get a job and he wants to get a job. So definitely working on in a job, how might this impact you? And that's what we see with our adults and our, young soon to be adults, really working on how does their hearing loss impact them and what are the strategies we can teach them? What are some other ways to communicate to help make sure they're being effective communicators in various job settings? And also, it's hard sometimes they don't know what they don't know. So how do they also work with their supervisors, their bosses, their coworkers to make sure the message has been received from them to them, or they understand what's being asked, what's being said, that kind of thing. So sometimes if they didn't hear it, they missed it. So can someone check in with this person, make sure that they know X, Y, and Z. So yeah, things where they miss too, when we look at pragmatic, they'll miss sarcasm, or they might not necessarily understand the figurative language components. So a lot of times too, the receptive repair strategies, repeat. Definitely sometimes for a couple of my clients, we have to say, hey, can you repeat that? Say that again. Let me make sure I understand what you said, and then repeat. So the tell me more. So usually ask more information, tell me more about, and then did you say? So a lot of times with a few of them, I have to reiterate what I think they said, and then they can confirm yes or no, or tell me in a different way. So this little guy, it sounds like he's got a severe hearing impairment. I use that with him quite a bit. So yeah, I wish I had some good, but he fits all the bills of somebody with a severe hearing loss. Oral rehab. So kind of hearing impairments, kind of defining those. Here are the different types. Here are some things that we do. The rehab, so let's talk about oral rehab. Oral rehab is a little more what I would call whole picture. So oral rehab isn't just getting the hearing aid or whatever the assistive technology device is to help them hear or communicate, and then just learning how to use it. Oral rehab is a little bit broader. So let me enlarge this. So our rehab really looks at what are all the things needed and how is the hearing loss is going to impact this person's life. So it's anything that facilitates hearing, understanding, coping strategies, acceptance, and then involving communication partners. So really looking at the client in a variety of settings. Can they hear? Can they understand their condition? Can they explain it to other people? Do they have coping strategies to address it and deal with it? And then also being out in the world. Hey, they have this disability or something that's different about them. Does that mean you can't live a fulfilling life? No, you absolutely can. And then involving the communication partners in this person's life. So really we're looking on taking the person and optimizing their environment and their life so it impacts them as minimal as possible. So I think when sometimes we look at rehab, we always want to say, I want to maybe steer clear from we're taking away the disability or the disability won't impact them, but we're trying to be sure that their disability is minimally impacting their life and they have a quality of life. Sometimes the challenges may not be exactly what the manner or the way in which they wanted it, but are they able to do things to the most of their ability in the manner in which they can? So really looking at that kind of broader picture of RL rehab. So auditory training, you can look at some of that. And basically in a nutshell, what that is, and they do it a lot with cochlear implant because they really have to work on using their technology to hear. So hearing aids, other assistive listening devices, auditory training is using, understanding their device and then using it in a functional way. So it's kind of that two piece. Basically, do you know how to use the device you have? And then you need to train your brain to use it to help you. So cochlear implant comes in this quite a bit. And there's a lot of some things too. There's, synthetic training approach. And instead of just, for me, I think I kind of steer towards functional, like, hey, you have a hearing loss. Here are things we know might always be difficult. They're not going to be perfect, but what can we do to minimize? So I like kind of maybe synthetic training. I've done minimal. I've had a couple clients where we're working on using their hearing aids, but let's look at audio rehab versus audiologic rehabilitation. So audiologic rehab is just the rehab that the audiologist does. So it's provided by the audiology people. That's the audiologist working with the client and their aid, their hearing aid or device. RL rehab is a little bit broader. So this might be some of the other social services and things they need. So you can kind of look at some of the variables. So what we're looking is rehabilitation versus habilitation. So this will be on here. You guys will get sick of hearing it from me. Rehab restores lost function. So this is sometimes someone who's acquired a hearing loss. We're working on rehab. Habilitation is where the skill was never there. So somebody with a congenital, moderate to profound hearing loss, somebody with a congenital moderate hearing loss, they haven't had normal hearing at any time. So there's kind of differences. So habilitation, you will hear it a lot in our special needs world. DDD uses HAB, and HAB really works on those functional skills on a regular basis. So rehab is where I think more, when I think of rehab, I think of more adults or young adults. Everything was typical, average, your average Joe walking down the street, and now something's happened. Now things have changed significantly, and now they're trying to regain skills that they had, or relearn how to, utilize the skills that they have left. sometimes we can, they lost their hearing, we can't really replace that, but can we help minimize the effects of the hearing loss? Yes, that's kind of the rehab component. So just be clear on those differences. And if you're not clear, please send me a message. I really, really feel like I don't want to be using those words interchangeably. So I was just talking to somebody about like adult neuro rehab. They've had a significant neurological event and they were totally fine, typical, not having difficulties, your average Joe walking down the street. Now, after their brain tumor that's been removed, 3, brain surgeries, now they're working on rehab. They're relearning how to walk, how to talk, how to do certain things. They were able to do it fine before. They didn't need any support. That's like rehab in the traditional sense. Habilitation, I kind of think, is always used with someone who they never had the skill present, but we're trying to develop the skill. So hab is more developing a skill they never had. Rehab is regaining a skill that they once had. So kind of those differences. Like I said, I don't like them. I feel like people use them interchangeably and I don't like that. So definitely looking at some of the adult rehab. So vocational. The nice thing is a lot of times there's some extra funds, federal funds for people with various levels of hearing impairments that they can access. And you kind of need a social service network to access that. So a lot of times outside agencies work with people with hearing impairments to access. So it's nice. Hearing and vision seem to have a little more resources from, government. There's some cool little handouts on here, preferential seating, FM systems. And I was just talking to one of my teachers I work with. She was saying, I'm like, everyone has amplification in their classroom. They have a microphone with their smartboard. So nice. Please use your assistive technology that we have already readily available. Some teacher wanted some, elaborate microphone system for a kid who had just a mild hearing loss. Like, no, he doesn't even wear a hearing aid, but he needs preferential seating. And hey, how about you just use the amplification you have in your room to support him? Okay. Someone asking about the hearing impairment, and I will tell you if there's one that's better. I don't think there's very good ones on Master Clinician. Okay, the read and review summary, there's an assessment, and then the read and review summary is the chapter 13 pediatric hearing loss. So there are some differences between adults and children. So look at that. And really, what's the evidence-based practice for that? What do we do with a child versus an adult with a hearing loss? What are some of those key pieces? It's in your chapter. So please refer to your book. Any other questions? Any other questions? Okay, if not, I appreciate you guys joining me tonight. Hope you guys have a good evening.